Good.
Oh, good morning, good afternoon, good evening, dear vascular surgery and angiology family all over the universe. I am honored today to present our sixth webinar titled Vascular Surgery Challenges. I would like to thank Survey Company for sponsoring this wonderful meeting. And I am also in debt and want to thank Dr. Martin Marsh, Dr. Mahmoud Salah, and Dr. Tariq Radwan for accepting our invitation to be speakers today. Also, I would like to thank Dr. Shoaib Badaria and Dr. Sandeep Raj Bandi, Dr. Amr Abdurrahim, for accepting our invitation and join us today. I'll take my chance and introduce our famous speaker today, Professor Martin Marsh. He's a senior vascular consultant of vascular surgery in BDF Hospital in Bahrain and serial lecturer in Faculty of Medicine and Royal College of Surgery, Ireland. He's author of many publications and he's invited speaker in a lot of international community and congresses. He's going to talk today about the hybrid approach in vascular surgery. Please go, Dr. Marsh.
Thank you very much. Thank you very much. Good evening, everyone. I hope I'm sharing my screen right now. And I have chosen the topic for tonight about the hybrid approach in vascular surgery in general. I like this talk. I have to be personal because it allows me to get deep inside into the vascular specialty, and I can tell you we all are blessed to actually work in the field of vascular surgery, because it's not many of specialties so exciting as the vascular surgery is. This talk is not about a particular technique, to be honest. It's supposed to be kind of inspirational talk rather than educational lecture, and it's about how important it is to think outside the box. It's also about the evolution of the specialty as it is, and on this path there have been many leaders and pathfinders on this journey, but I have picked three of them. I've picked three of them because these three physicians, they've been from the different backgrounds and different specialties. What they had in common was the same focus. They got in love with the circulation. The first of them was a radiologist. He was the oldest one, Charles Daughter. He was born in June 1920. He was an excellent student. He skipped a grade in a grammar school, and he started his professional career in Oregon University. He was actually only 32 years old of age when he was the youngest person ever to be named as a chairman of a radiology department in a major American medical school. And he would remain in that position for additional 32 years. And it was in 1963 when he accidentally recanalized an occluded right iliac artery by passing percutaneously introduced catheter retrogradely. He was actually doing the aortogram for the abdominal aorta, and this was just the incidental procedure. But it was perhaps the most important incidental momentum which has changed our specialty forever. And he reported about this treatment at the Czechoslovakian Radiological Congress, and I like it because many of my senior colleagues, they remember this. and they were talking about this because the Czech Republic is where I'm from and where I was working in the university hospital, and they were discussing it, and they remembered Charlie daughter actually talking. This was 1 hour talk, and it was presentation about angiographic techniques of future. And this was the moment, this was the meeting when he said that the angiographic catheter can be much more than just a tool for a passive means. And it can be used, if it is used with imagination, it can become an important surgical instrument. And it's amazing, you know, he saw the future in 1963. Because then very early they prepared the elective case, and it was 1964, and daughter and his trainee Melvin Judkins, they used the catheter for intentional percutaneous angioplasty. The doctor himself, he was very flamboyant person. He was very active, and many of his colleagues remember him as a crazy Charlie. He was very aggressive in treatment. He was a mountaineer, and he was very focused. This is the Carlo Vivari, and this is his first patient, the patient who underwent first intentional percutaneous transluminal angioplasty of the SFA, 83 years old lady, Laura Shaw. And you can see her, and after successful treatment, actually she was cured from the critical limb ischemia. But this was not yet this angioplasty was actually made by the catheters pushed over the wire, and not the typical balloon angioplasty as we know it for these days. For this, he needed another colleague, his friend, a bit younger, Thomas Fogarty, who was born on February 25th on 1934 in Cincinnati, Ohio. Fogarty, unlike Charlie daughter, was not very good student. His original career goal was to be a boxer, actually, and perhaps it was because he lost his father. But then he got a mentor, and this mentor actually focused him on a right path. And he graduated summa cum laude in 1960 in Cincinnati from the medical school. And he started in University of Oregon, which is the same institution as Charlie daughter was working. And Thomas was, I've met him in California, in San Francisco, and he was, since he was a student, he was working as a helper at the surgical department, and he was not very happy about the outcome of the patients treated with acute thrombosis, because these days the mortality was very high. It was more than 50%. Like majority of these patients die, and it was very difficult to treat them. And he came with this idea of remotely treating this patient with the catheter and the balloon. And actually he came up with this device before he graduated from the medical school, about the very simple device of the catheter with the balloon at the one end and the syringe at the other end. This was a very soft latex balloon, because it was very important that it was not injuring the intima and the artery by during the pullback maneuver. And the first balloon angioplasty using his catheter was performed in 1965 by the head of surgical department that day. And Charlie daughter was in touch with Fogarty, and he was trying to use his balloon to perform the peripheral angioplasties. But the Fogarty's catheter, the Fogarty's balloon was made from the tip of the glove. And so it was a latex balloon, and it was very soft actually to push aside the atherosclerotic plaque. Anyhow, he patented his device in 1969, and Edwards Life Sciences from California the company was assigned the patent to begin manufacturing the Fogarty embolectomy catheter, and it's estimated to have saved the lives and limbs of approximately 20 million patients, which is just amazing. And Thomas was very clever. The moment he patented it, he became millionaire, and he's a very rich man, and he bought the wineries and he left surgical field, and he's enjoying making wines nowadays. the third of this trio of friends is Andreas Grunzig. He's my favorite, most likely the smartest of them. Obviously cardiologist. He was the youngest one as well. He was born at the beginning of the Second World War, 1939 in Germany. And his father got lost during the Second World War. So he was left with his brother and his mother. But the mother was taking really good care about both of them. And she made sure that they got a very good education, and even his brother actually became a doctor. He's still alive, practicing medicine. He himself, the Andreas, he graduated from the Heidelberg University, and then afterwards he was extremely smart. So he planned his career from the very beginning in a very clever way. So his studies included internal medicine, so he got some general knowledge of the diseases, and the vascular surgery as well. But then he shifted to the occupational medicine, studying the cardiovascular risk factors. And then he spent 6 months fellowship to study epidemiology in London, and he became very good in statistics, and this helped him a lot. In a later stage, he was amazing playing with the statistical numbers and figures, and he was very precise in forming the hypothesis and confirming his hypothesis. And then he worked in the department of angiology at the University Hospital of Zurich. He was appointed by Robert Hegling, who was actually successor of Leffler. Leffler was the founder of Circulation journal. What is really interesting is that Hegling himself, who was the head of department of the surgery, he unexpectedly died from abdominal aortic aneurysm rupture only 3 weeks after Andreas Grunzig was appointed in his department. So Andreas was transferred to Alfred Bollinger's angiology unit. Angiology is a department of vascular medicine. It's a very strong specialty in Europe. It's not very popular here, or it's basically unknown, but the angiologists are internal medicine specialists focused on vascular disorders. And he was also trained in radiology department, so he was very good in performing the angiograms and everything which was linked to the X-rays as well. And he was aware of Charlie Daughter's experiments and first successes of treating the vascular diseases remotely on distance, and he was thinking about how to tackle it, not with the catheters as the dilators, but with the balloons at the end of at the tip of the catheters. So he started experimenting with the catheters and the balloons at the very end, and he actually performed the first peripheral angioplasty in 1974, and he was the first one who named it percutaneous transluminal angioplasty as we know it, and he patented the balloon as well. He was in touch with Charlie Daughter, and they became a friend as well, and they were working on the same concept basically for many years. By that time, as you can see, he was fabricating the balloon for each patient. So the treatment that time was basically custom made. So each patient got the balloon according the need of the size and the length of of the of the pathology itself. So he came with the concept of double lumen catheter, which can be moved over the wire. Later, he got interested in treating the coronary arteries as well. And he was doing experiments in the coronary arteries, which was quite sensitive field. And he experienced a lot of hostility from his colleagues in Switzerland. He was stopped many times to be doing it. And there is a famous quote of Professor Ake Senning from the cardiac department, who was very keen and who was supporting him. And he said, "Mr. Grunzig, you will be taking away my patients later, but get started right away," because he felt like this is the future treatment. And Andreas Grunzig, he has started, and he attempted to perform his first percutaneous coronary angioplasty in March 22nd in 1977. But this is very important story to tell, because this was a patient who was declined by surgeons previously. He was very sick, and it was unsuccessful attempt. And the Grunzig, he talked about this attempt a lot later. And he said, if you are trying something new, don't take the patient, don't follow the contraindications for other treatment. You have to choose the best patient for your method to be successful. So it's imperative to start a new technique with a good indications and not with the contraindications for another techniques. So then in September 1977, he planned and he succeeded with the percutaneous coronaroplasty. And this was the beginning of changing the cardiology and cardiac surgery as we know. He was actually one of the first physicians who was delivering this kind of educational platforms as we know today. He, in between 78 and 80s, he executed a couple of live demonstrations courses. This was the first time actually when he was transmitting the live procedures from the cath lab, and he was discussing with the audience while being with the patient who was undergoing the procedure. This is what we know nowadays, and and what is important, the Grunzig actually admitted that it was during these live demonstration courses that he learned the most from the comments and the questions of his peers. That's why this is extremely important to meet friends and colleagues like we do here and discuss and take the best out of these discussions. And Grunzig and Charles' daughter actually received the nomination for the Nobel Prize in Physiology and Medicine in 1978. And it's really ridiculous that they haven't been actually awarded. That year, it was for the discovery of restriction enzymes and their applications to the problems of the molecular genetics. And it's really funny that they haven't got the Nobel Prize. Unfortunately, then in 80s he went to United States, and I guess in 1980s Harvard and Cleveland Clinic offered him a position, and he accepted an offer from Emory University in Atlanta, where they created the special department, which was very generously funded financially by, I guess, Coca-Cola company. And he did like 3,000 procedures within like 5 years. He was a very prolific surgeon. Unfortunately, he was also an instrument-rated pilot, and him and his wife died in an airplane crash in October 1985. So he was only 46 years old when he died. anyhow, these three friends, they have started what we can call the revolution in vascular surgery, because they shifted from open to the endovascular techniques. And beside the revolution for the patients, they sparkled also the huge discussion about what is better, open procedures or endovascular techniques. And I still remember my professor, it was late 90s, when I came up with the idea of endovascular techniques in our department. And he said, Martin, balloons are for children, forget about balloons. And, but he was an excellent surgeon, but he was obviously not right. And we all remember a lot of arguments pro and contra open or endovascular techniques. But I think these wars and fights are over because there's so many patients, then we can just share, experience. What I think is not about either open or endovascular techniques. The best vascular service is the service where open surgery and endovascular are offered at the same high level expertise, the same time. And very often we can combine the advantages of them both. And this is the hybrid approach. It's basically combining open and endovascular techniques. Maybe it's just a step towards the full endovascular procedures. And it's perhaps just a matter of time and matter of technological improvements to get to the point that we'll be able to treat all the patients by endovascular techniques fully. The principle is to get the maximal benefit for the patients and at the same time decrease the risk for the patient. And we can combine these techniques, open and endovascular, either in one session or in a state fashion. This idea of combining these approaches is very, very old. As you can see, it's nothing new. The first case was actually reported in 1973, which is unbelievable. If you remember the dates I just told you about the evolution of these techniques, and it was iliac angioplasty and femoral bypass. What is really interesting that it was actually published in the Gynecology and Obstetric Journal. So what you need to provide the hybrid procedures successfully is a proper hybrid theater, hybrid OR. You need a high quality angio machine. It's not good if you start with compromising yourself. You need a good endovascular tools, the full set of endovascular tools. So if you have any complication, you are able to solve it endovascularly. You need a proper endovascular training and endovascular skills. You have to be careful about the radio protection. And nowadays there are standard hybrid theaters. This hybrid approach you can basically use in all spectrum of vascular pathologies. You can use it in peripheral arterial procedures, acute limb and chronic limb ischemia. We can use it, and we use it in venous procedures in treating venous pathologies, aorta, or you can use also hybrid approach in treatment of arteriovenous grafts for dialysis. So in case of treating critical limbs, what we know about the open approach is that it obviously increases the cardiac risk. If there is a wound, there is a risk of wound complications. About 1/4 of these patients, they need reintervention at some point. And sometimes we are limited by the anatomical limitations. Anyhow, the amputation-free survival is quite optimistic. In regard of the endovascular treatment for critical limbs, there is possibility of excess complications, even though with the small French sheets as we use nowadays and the ultrasound guidance, these complications are less and less common. Sometimes we need a long-standing and thus reintervention rate might be increasing as well. We use the off-label procedures. And we have to be concerned about the radiation because these procedures are usually technically challenging and they need a lot of time and radiation, and also the contrast is an issue, even though we use nowadays much more and more CO2 angiography in our institution. And the amputation-free survival is basically very much the same in comparison with the open procedures. So the hybrid approach in saving limbs, in critical limbs, the key is that the groin is always open. The groin is the key, and dissection of the femoral bifurcation. And then there are two options. The first is to intervene approximately and by endovascular means, and it means the aortoiliac angioplasty and stenting with some kind of infrainguinal reconstruction, either endarterectomy and profundoplasty or femoral-popliteal bypass. The other way around is the common femoral artery endarterectomy or femoral-popliteal bypass and endovascular intervention below the knee with angioplasty of the popliteal and tibial arteries. The hybrid approach in acute limb ischemia is very much alike, and again the femoral bifurcation is always dissected and open, and then we usually perform the proximal and distal thrombectomy with the Fogarty catheter, and then if patient is in need of treatment of underlying stenosis, then we perform the iliac angioplasty and stenting, or run-off angioplasty, again the popliteal or the tibial arteries, or if the thrombosis is extensive all the way to the tibials and we are not happy with the runoff on table, we can just run perioperative thrombolysis. Just to illustrate this treatment, I will show you one case of 64 years old teacher here in Bahrain, very nice gentleman, who was unfortunately smoker, diabetic, atherosclerotic, and this atherosclerosis was very accelerated. He was post couple of cardiac procedures, CABG, angioplasties, uncontrolled diabetes. And he was previously treated by cardiologists, and he ended up with 7 stents in his superficial femoral artery. He was brought to our ER with acute onset of severe rest pain. And when we shoot the CT angiogram, then this is what we found. The 7 stents inside his SFA were completely occluded. We found in inflow severe stenosis at the bifurcation, and 2 out of his 3 tibial vessels were completely occluded, and the posterior tibial artery was severely stenotic as well. So very, very severe multi-level finding, which put you into a very difficult position, obviously, how to treat. So we decided and we opted for the hybrid procedure. You can see the patient post harvesting of his great saphenous vein, and you can see 2 sheets inserted, the one in retrograde fashion, the one in the antegrade fashion through the graft, and the anastomosis distally. The bifurcation was treated with kissing balloon stents, and the distal antegrade sheet was inserted through the anastomosis, and the PT was treated with the angioplasty all the way to the pedal arch. So he ended up with the kissing iliac stents, femoral popliteal bypass, and the below the knee angioplasty, and he left the hospital by walking, and he was very happy about the outcome. How about the hybrid approach in the venous interventions? The the venous reconstructions, the cause of the venous reconstruction is usually chronic DVT. Usually the patient suffering from post-thrombotic syndrome because of the proximal occlusion of the veins. This this post-thrombotic syndrome, as you can see in the literature, is the data showing something around 25 to 75%. To me, honestly, if there is proximal occlusion, all these patients are suffering from some kind of post-thrombotic syndrome. Just some of them don't care about some kind of heaviness, swelling of the lower limbs, but in majority of the cases, these are symptoms which deteriorating the quality of life of these patients. And very often these are the young patients, like this gentleman who was 27 years old boy who was cycling 15 years back with his brother, and he fell down and broke his femur, and he got deep venous thrombosis, and he was not treated at that time, and there was occlusion left in his femoral all the way up to the IVC. And this venous ulcer over his left ankle was very difficult to treat, and it was on and off there for like many of years, and he was unable to get a job because of that, and he was unable to have a family as well. So it's really serious consequences. And the goal in these cases is to provide an unobstructed venous drainage from the deep femoral vein to the IVC. And really the deep femoral vein, the profundal vein, is a key factor. And to get the outflow, to get a good flow from the deep femoral vein, there is a lot of discussion about crossing the inguinal ligament, but in these cases, this is very common, and you have to do that. And if you don't do it, you will see the early instant thrombosis, because if you don't have inflow, if the blood is not running inside the stent, it will get occluded soon. So you have to get into the deep femoral vein. And if this is not possible by endovascular means, then you have to deliberate the deep femoral vein. And this is what we call endophlebectomies. So we open the groin again and dissect the femoral vein, and you can see the thrombus there. And endophlebectomy is very much alike the endarterectomy. The only difference is that endophlebectomy is much more difficult technically, because it's very difficult to get rid of the thrombus later. Here you can see the endophlebectomy of the deep femoral vein, which is here. This was impossible in this young gentleman to get an inflow, and then the phlebectomy was the only chance. This is the cleared femoral vein, and this is the angioplasty and the patch using his contralateral saphenous vein. And immediately afterwards, we got the sheath into this segment and finished the procedure with a venous stenting. And here you can see how nicely it works with the veins. The boy still having the dressing, so this is about like 10 days after the procedure. You can see the significant difference in edema, and you can see almost healed venous ulcer. So it's really like a magical treatment in a venous pathologies. I don't want to bother you too much to go into each procedures. There is a lot of hybrid procedures treating.
Excuse me, we have only 2 minutes because we
I'm finishing. So these are the aortic hybrid procedures, the whole broad spectrum of it, debranching procedures, Evita procedures, but as Dr. Raymond said, there is a short timing. So as I said, this is supposed to be inspirational talk to just remind you to keep the mind open and always think about outside the box and use all the tools, and try always indicate the procedure according to the need of the patient, not according to the preferences of the operator. So thank you very much for your invitation, for your attention, and Ramadan Kareem to you all.
Thank you, Martin. It was very interesting talk, really, and to came through all the history to see what we are going to do now. And I will take the chance to welcome Dr. Atif Salam from Atlanta, Georgia, United States, and Dr. Muhammad Shemari from Saudi Arabia. Welcome to the board. And I would like to ask Dr. Atif Salam, because he is Emory fellow, and I think he has to comment of what did Dr. Andreas in Emory as a witness on that event. Can you tell us, Dr. Atif? Dr. Atif?
Ayman, I enjoyed Dr. Martin's history review. You know you're getting old when you find out that you met personally with at least two of the three. Dr. Grunzik, as Dr. Ayman knows, came to Atlanta at Emory, and he did introduce coronary angioplasty, and every 2 weeks we had like 6 or 7 buses bringing people to Emory to learn the technique. He was a very smart person, very innovative, and Emory has a little museum for him. His wife was a student of mine. She was the only daughter, and unfortunately on a Sunday, as you just heard, I was doing an emergency at Emory, and a mutual friend came to tell me about the crash. He was an excellent pilot. The weather was very good. It was a flight that takes 45 minutes. Still, it's a mystery how this happened. Also, Dr. Fogarty, we were on a panel at times, and I invited him to Emory when I was the president of the Atlanta Vascular Society. And again, he is a very creative person. Let me ask Dr. Martin, again, I enjoyed your presentation. I have some questions for you about hybrid intervention, which I had some interest in. When you do an endarterectomy in the common femoral artery, which is when the disease involves the iliac, the common iliac artery as well. Starting with an easy case, if the angio showed that it's only incomplete occlusion and you plan to do the hybrid procedure. You do the femoral endarterectomy and the patching first, and then go retrograde to treat the iliac lesion, which is almost the standard practice now. At the beginning, I was concerned about retrograde access to the iliac artery and the risk of dissecting the proximal end of the intima where the endarterectomy ended. So I was reluctant. Thought I would do the iliac first, but then we found out that this is not a really great risk. So we do the patching first, and then go through the patch to do the iliac endarterectomy. How about a patient with complete occlusion, long segment of the common iliac, and the chances of success may be limited? Do you go from the other side, or you are ready to do a fem-fem bypass in proper cases? Again, I enjoyed your presentation. History is really very important, and it is a sign of maturation of the society when you include history for the younger people to realize how did we get where we are now. Thank you again.
Thank you very much, Dr. Atif.
Dr. Martin, can you reply to the second question for Dr. Atif for total occlusion?
It's my great pleasure and honor to answer such a question. It's fascinating, Dr. Atif, that you know all the persons and the pathfinders of our specialty in person, and you can remember them. I'm not that old, but I've just met a couple of colleagues of mine from Czech Republic who were sitting there when Charles' daughter was delivering his legendary talk about how the interventional radiology was born, basically. It would happen in Karlovy Vary in Czech Republic. In regard of your question of the iliac occlusion and additional femoral endarterectomy, I have tried both. I did first the recanalization because my techniques are evolving as well. So the first opening the iliac and then performing the endarterectomy, it always depends on the pathology itself. What I do for the complete occlusions, which are basically continuous all the way to the groin, I do cases with the Folmar rings catheters. You know, in this case, if it is complete occlusion, what I do, I extend my endarterectomy proximally with the Folmar rings, and I'm trying to deliberate the iliac artery as much as I can. And even if it is incomplete, then at the very end you can get your wire into the dissection plane and finish it with the carrot stand all the way up and get the nice inflow. And then finish the endarterectomy. If it is just stenosis, then I do what you do. It means the femoral endarterectomy and profundoplasty, and then I insert the sheet through the skin and the patch to treat the proximal lesion.
Thank you, Martin. Before we go to Omar and questions from the attendees, I may ask Dr. Badaria if he has a comment.
Yes. First of all, Dr. Martin, it was a lovely lecture. I learned a lot about the history and it was a revision. You know, in our country, like India or Egypt for that matter, the introduction of hybrid procedures has been a great boon to us for two reasons. One is that a lot of patients who come to us with multiple comorbidities, and these hybrid procedures help to avoid multiple interventions and multiple admissions in the patients. And the second more important thing is that by doing a hybrid procedure and avoiding repeated admissions to the hospital, the overall cost of the procedure is decreased quite significantly. Apart, of course, from the medical fact that the results are much better. So in a situation like ours, the hybrid procedure has proven to be very good. On the other hand, we have some limitations. We don't have really a hybrid laboratory or hybrid operating theater. But what we do is we manage by maintaining proper sterility of our DSA laboratory, bring our surgeons in, and we work totally together, and we achieve fairly good results with similar infection rates as if it would have been in a regular hybrid theater. I think we are getting there. Thank you once again.
And thank you, Dr. Badaria. Now I go to Omar because I see some questions for the attendees. Please,
Okay.
Omar, the mic is yours.
Okay, I would like to welcome again Professor Mohammed Shamri joining us from Saudi Arabia, one of the most famous intervention radiologists. So I have three questions. The first question by Miguel Alfonso Beraza Ajona. Please, your mic is open and you can ask your question to Martin. Miguel? usually take about 10 to 15 seconds for the mic to open. Okay. Miguel Alfonso? Yes, you can speak now. Miguel? Okay, there is a problem, I think, with his voice. We'll take the second attendee, Tariq Azab. Dr. Tariq Azab, you can ask your question, introduce yourself, and ask your question to Martin.
His mic is muted.
Yes, it takes about 10 seconds for it to unmute. It will unmute now.
In the meantime, Omar, I can answer one of the questions. There is a question about the antiplatelets and the heparin during hybrid procedures. So what I do, I never stop aspirin, but I'm trying to do it without Plavix. I keep this patient on full heparin, and usually even after the procedure, I keep higher heparin according to the ACT time, and I start loading dose of Plavix the very next day.
Okay. It seems there is a problem with Tariq mic. We have a question from Samer Qusayr from Saudi Arabia. We can bring in Professor Samer, one of the most eminent vascular surgeon in the Middle East. Your mic is open, Samer, to ask Martin. Samer Qusayr from Saudi Arabia. Okay. I hope the mic will open now. Samer?
Hello?
Yes.
Hear me?
Yes, we can hear you, Samer. Go ahead.
Hi, guys. Sorry I came late so I didn't hear the whole lecture from Martin. So hopefully, I don't know if guys you mentioned that or not. Just small comment. I just want to mention that there's a new paper from the United Kingdom, published journal GVS, I think last month, comparing open repair versus endovascular for aortic iliac disease. And they have subgroup where they look about endovascular repair of aortic iliac versus hybrid repair, where they combine femoral endarterectomy with the iliac intervention. And they found that the primary patency is much better for hybrid repair. So already now is very recommended that you do hybrid repair for aortic iliac occlusive disease, especially if you have some disease in the femoral. So I just want to mention that and just be sure that, is everyone agree on that?
No, this is perfect comment, Samir, and thank you for that. And it's actually common sense because we know that the outcome, for the stenting in aorta iliac is amazing. It's perfect, and we know that. But we know it doesn't work yet very well in the femoral region. So the combining of and opposite, the open techniques in femoral bifurcation, the profundoplasty has been proven for many, many years, for many tens of years. So combining these excellent methods, so iliac balloon angioplasty plus minus stenting and femoral endarterectomy with a venous or dacron patch to improve the profundal outflow is just the best treatment you can get.
Yeah. I agree with that, and hopefully we can discuss this paper, I think maybe next week or week after our journal club. But it's a very nice paper to look at that. And it was very obvious, was very significant, statistically significant, the difference between pure endovascular versus hybrid repair.
Excellent. And let me take the chance to offer Professor Mohammed Al-Shammari. I know his mic is open and he's been with us from the beginning of the webinar. Okay. Do you have any comment, Professor Mohammed Al-Shammari, to Martin? Your mic is open.
Salam all. Can you hear me now? Salam all. I hope you can hear me. A very nice talk, Martin. I really learned a lot about history. Now, really, I think the new hybrid should be the combination of specialties, surgeons, cardiologists, interradiologists, and angiologists developing endovascular techniques. Now, you see many people now going crazy in deep arterial, deep venous arterialization by just endovascular. I think simply combining a simple hybrid procedure with it can help, a surgeon and opening to the artery and the vein, a simple cut can avoid a simple complex endovascular technique. So I think really I would love to see a hybrid combination of specialties and advancing endovascular techniques for patient. That's my hope.
Mahmoud, this is a great comment, and it's just very obvious that it just proves your wise mind and open mind. And it's very obvious it's not only our two specialties, but the good vascular service nowadays must be a combination of the vascular technology, of the vascular medicine, of the surgery, interventional radiology, and even cardiologists, angiologists. And without combining all these specialties, you just cannot get a good vascular service nowadays because it's so complex that you just cannot get along.
Yeah, excellent. Thank you very much for this nice discussion. And it's back to you, Professor Ayman.
Thank you, Omar. Thank you, Martin. And thank you for the panel and our attendees. Now, the time for Professor Mahmoud Salah. Professor Mahmoud Salah is a Chief of Vascular Surgery, Saudi German Hospitals Group, and Chief of Surgery also in Saudi German Hospitals Group. He's a Professor of Surgery in the Batarji Medical College and Examiner of the Royal College of Ireland. Dr. Mahmoud is going to talk today about the re-implantation limb surgery. Please, Dr. Mahmoud.
Thank you very much, Dr. Ayman, for this very nice introduction. Can I start sharing my screen?
Yes, you can. We're all eagerly waiting for this lecture, Professor Mahmoud. You press on the green button at the end, yes.
Okay. So I'm going to talk about re-implantation, or what we call replantation of the amputated arms. I divided the talk into three categories, just 10 minutes each, including the questions. Amputated arms is really a very challenging and difficult situation that can face any hospital, to have the patient brought with the arm in a separate bag. Decision whether to finish the amputation or to do re-implantation is a really crucial decision and should be taken very quickly. Unfortunately, there is no known objective scoring system or clinical evidence to predict the functional outcome and make the decision easier. We don't have some such thing that we can say that this we will amputate and this we will re-implant. Actually, the majority of the published research on major upper limb re-implantation originates from case series and recommendations that are based mainly on experience. So decision to proceed or not rely heavily on the surgical team, experience, courage, and skills. Decision should depend on, of course, the condition of the patient, life-saving first, condition of the amputated arm, well preserved or not, condition of the stump, technically feasible or completely crushed, type of the injury. Of course, the sharp one is the best. The crushing and the traction are the worst. Time elapsed since amputation. The experience of the surgical team. So the indications, any amputation in a child should be tried to be re-implanted. Amputation of the thumb is half the function of the hand. Multiple digit amputations should also be re-implanted. Mid-palm or hand amputations, and of course higher amputation at the level of the wrist, forearm, or arm. How about contraindications? Contraindications, of course, any life-threatening injury. Okay, sometimes the patient is having a lot of injuries and this amputated arm comes at the end of the list. Severe crush injury, multi-level amputations, major psychiatric illness, if the patient is having impaired function of the extremity from before, or prolonged warm ischemia of the amputated limb, this should not be tried actually. The ischemia time irreversible ischemic injury occurs in the muscle tissue after 2 to 4 hours of warm ischemia and 6 to 8 hours of cold ischemia. The digits lack the muscle tissue, and so they can withstand more time, tolerating 6 to 12 hours of warm ischemia and 12 to 24 hours of cold ischemia time. Age, of course, children shows better functional recovery than adults, and replantation should almost always be attempted. In addition, replanted parts appear to demonstrate normal growth after that. Anticoagulation, of course, thrombosis is the most feared short-term postoperative complication. And thrombosis usually occur in the veins. Although there is lack of strong evidence, yet the recommendation is to use anticoagulants and antiplatelets. Secondary reconstructive surgeries, usually the patient needs, whether early or late, but some procedures like tenolysis, neurolysis, nerve transfer, tendon transfer, soft tissue coverage, whatever, non-union, malunion, all these needs. So it's not just one operation. You have to follow the patient. Metabolic changes after the, mainly it's reperfusion injury. The patient, systemic acidosis and even shock can occur when the venous flow is reestablished. Rhabdomyolysis and myoglobinuria may also cause cardiac arrhythmia or renal failure. Core principles, these are very important principles. The major goal is to re-establish lymph perfusion and minimize the ischemia time. Sometimes you need to think outside the box for this. Sometimes if you have an amputated arm and you still need to do anything in the patient, you can start perfusing this arm from the other arm. If the patient is having internal hemorrhage or hemothorax or something like that, and you don't want to lose the limb, you can revascularize this limb from the other limb for 1, 2, 3 hours till the patient can start the re-implantation. So you need to think outside the box. Second one, replantation usually begins with bony fixation, followed by arterial repair. Of course, bone shortening is crucial. This can make life easy for any anastomosis. Nerve anastomosis, artery anastomosis, vein anastomosis. Just shortening 5-10 centimeters of the bone will make life easy in all the anastomoses. Of course, venous anastomosis is a must. Minimum 2 veins should be anastomosed. Nerves should be repaired primarily. This is not like the usual trauma that you can mark the nerves and then for later repair. No, this should be repaired primarily. Then muscles and tendons. Skin coverage can be left open for later grafting. And very important step, which is prophylactic fasciotomies. This is the systematic review done about 500 patients comparing the replantation versus the prosthetic fitting in traumatic arm amputation, and they had this result. Replantation of a traumatically amputated arm leads to good function and higher satisfaction rates than a prosthesis, regardless the objective functional outcome. And sometimes the objective functional outcome is not perfect, yet the patient is much more satisfied than the prosthesis. Sensation and psychological well-being seem the two major advantages of replantation over prosthesis. I'm presenting just a couple of cases. This is a 29 years old, had work injury by iron cable, complete amputation of his left arm. He was brought within 1 hour and decision was to re-implant the, you can see this is the amputated arm and this is the stump, very nasty crushed wound. We thought even it's this articulation, but actually it was very high amputation. Then the bone as we said, the bone was fixed internally and externally. One way of fixation is not enough. The bone was fixed from inside and from the external fixator. Then this is the brachial artery fixed. This is the vein anastomosis. Actually, it was the cephalic and the basilic veins connected together to one vein. This is the median nerve repaired. And this is the ulnar nerve repaired. And this is the fasciotomy, forearm fasciotomy. And this is release of the carpal tunnel, also considered part of the fasciotomy. Plus also we do hand fasciotomy for the dorsum of the hand. This is the patient about 10 days post-operative. The same. Second case, 25 years old male had electric saw injury, cutting off his right forearm completely. Brought within 2 hours and was taken to the OR. This is the right forearm, and this is the rest of the amputated forearm and hand. Again, the bone was fixed first, again by 2 ways, by intramedullary nail and wiring, and then the radial artery was repaired. This is the ulnar artery. This is the X-ray just to show the wires and the intramedullary nails. This is the muscles starting to be repaired. This is muscle repaired. And this is the cephalic vein repaired. By the way, you don't have to connect the cephalic vein to the cephalic vein. Maybe you cannot find this, but any vein in the distal should be connected to any vein proximal. This is the immediate post-operative. This is 1 week post-operative, 6 weeks post-operative. And this is, again, 6 weeks. The patient can move his fingers and can move his wrist also. This is 3 months post-operative. And this is the bone completely healed, complete union. This is 4 months after we removed the nails. Only the wires are still there. And this is the patient 6 months post-operative. He's pinching a pen. So my take-home message today, although re-implantation of the upper extremity is a very demanding procedure, yet it's a well-established method in the treatment of amputation injuries that has a substantial socio-economic impact. These cases comes only when you are not ready. The issue is how much time you need to be ready and collect the whole team, the orthopedic, the neurosurgeon, the plastic surgeon, everybody. You may not have done such a case before, but you may find yourself heavily involved and the only one available for the job. Make sure of the decision of re-implantation, as it will give high hopes to the patient and family. Never give false hopes for training purposes. This will cost a lot of money, time, and effort. Make sure your hospital can accept such a case, as you will need all the support of everybody in the hospital, technical support, financial support, and administrative support. Never forget that sometimes amputation is a life-saving, while re-implantation is not. Thank you very much.
Very great talk, Dr. Mahmoud. I liked it very much. Really,
Thank you very much.
It is a must to talk and to work as in such a harmony. Congratulations for that. I see Dr. Amr Abdelrahim raising his hand. Dr. Amr, you can ask Dr. Mahmoud or comment, whatever you like. Dr. Amr Abdurrahim, please open your mic.
And welcome Professor Tamer Qusayr to our panelist. Yes, Dr. Amr, you can speak now.
It says, thanks, Dr. Mahmoud, for this very nice presentation. Is my voice clear now or not?
Yes,
Yes.
we can see you and hear you. Yes.
Yes. You've mentioned, Professor Mahmoud, that you need a full equipped team for such a complicated operation. But sometimes this is not the case in an emergency. Not all the team is fulfilled. So for a hospital that may face this problem, is it some sort of communication between the a major hospital or the tertiary or secondary hospital before referring the patient to the tertiary hospital to complete their job? Is it some sort of goal to help these patients?
Thank you very much, Dr. Amr, for this question. Actually, usually the accident goes to the nearest hospital. Maybe this is not a tertiary hospital. Of course, it has to be, hospital with different specialties. But if you have an orthopedic, the orthopedic will tell you, well, I can fix the bone. Has nothing to do with the decision, or I can fix for you the bone. And the neurosurgeon, even if you don't have neurosurgeon, anybody who is working as microsurgeon, he can repair the nerves. But all of the team will keep looking to you as a vascular surgeon. If you said, we are going to do re-implantation, they will follow you. If we said, no, this cannot be done, خلاص, everybody will go for amputation. It's very difficult to have very experienced subspecialty in all the departments unless you are in a tertiary hospital. But even if you are not in a tertiary hospital and you want to transfer the patient and the part to this to another hospital, you can still do something just to give some time for the transfer. As I said, you can just cannula in the artery of the brachial and another cannula in the vein, and you connect to the amputated arm. This will keep supplying the amputated part till you transfer the patient to another one. But don't take the decision of amputation because you think that your team is not experienced. Believe me, no team is experienced in this. But you have, if you were thrown in the sea, you will swim. I know that.
Hey, Dr. Mahmoud.
Thank you.
I see Dr. Martin have a question, but I'll ask you a little question before let Dr. Martin take his one. As they used to tell us in doing implantation, repair the vein first. What's your comment about that?
No, the artery is the crucial one. You have to do the bone, then the artery, then the vein.
Okay. Dr. Martin, please, you can get...
I just take this opportunity to congratulate Dr. Mahmoud. I was looking forward to the lecture, and obviously I'm delighted, as always, Mahmoud, about your lectures. And I want to congratulate you because this is so impressive work, you know, and especially working in a private hospital, you are doing a great job. These were so impressive cases. It's like, and as you said, it's a very sensitive area. Reimplantation is sensitive from all the points you can imagine, financially, you know, cooperation-wise, and that's perhaps the most important for me because you have to put together so many specialty, and that's actually where we face actually the most difficulties is to put everyone together. And I was about to ask about the reimplantation of the nerves, because the worst part, we have had a couple of cases, and the worst part are the neurosurgeons. You know, we can push the orthopedics to help, and they are usually there all the time. The plastics are always there, very helpful. But the neurosurgeon from some point, I don't know why, they keep talking about like, do whatever you want, guys. You know, we'll get later on involved. Like how? But you said opposite, obviously, and I feel the same. And I have a lot of discussions with neurosurgeons about this, and I'm a little bit disappointed.
Thank you very much, Martin, for this nice comment. First, I know that it's very difficult to work in a private organization and do such case. But that's why I said the hospital should be accepting such a case, because you are speaking about so much money, effort, and usually when you have the patient coming from with the accident, you don't look for money or approvals or company or whatever. You just run with the patient to the OR. That's why I said the administrative part should be with you, okay? So all the hospital should be collaborating with this. Number two, about the neurosurgeon, believe it or not, these two cases were done only by me and the orthopedic surgeon. We, as you said, we couldn't get the neurosurgeon, so we did the nerve, because the nerve, you have it in front of you, okay? You shorten the bone, so you don't, it's like you are doing a small arterial, you know, I'm not encouraging to do this, but this is
exactly what I wanted to hear. This is exactly what I wanted to hear from you. But then there are legal consequences of doing it. This is what I feel the same. It's at the front of me, and put a couple of stitches. I know how to put these stitches. But the problem is there is a lot of legal consequences then, you know?
Yeah, but I mean, you are in a situation either to follow their advice, just to put a mark here and a mark there and close the patient, and they will never open him again till he has complete healing and this thing, and he will lose all these nerves. So I think with shortening of the bone, freshening of the ends of the nerve, you can do it. If you have some experience in the microsurgery, you can do it. And I know, Martin, that you can do it.
Great.
Can I add something, Mahmoud?
Yes, please, Sam.
Yes, please, Sam.
Yeah, you know, we don't have much experience here in King Faisal because, you know, we're not trauma centers, but we have a couple of cases where they have like a bad injury, not amputation. But my understanding from neurosurgery, I think I talked to them many times, they said you should not, you're not supposed to repair the nerve right away. You can wait until, I think, until like 2 weeks. So there's no rush. They go on, they told me, go and do your part, you know, fix your artery, fix the vein, and they come later on when everything's clean and they can connect the nerve. So if I'm not mistaken, you don't need to repair the nerve right away. You have up to 2 weeks to repair it.
I completely agree, and this is also their opinion, that you don't need to do something right now. You don't need to wake me 3 o'clock in the morning to come for a nerve that we can repair after 2 weeks. But if you have the nerve in front of you, I showed you the picture of the median nerve. You cannot leave it. You know, it's in front of you, easy to come. You don't need to do any dissection. So that's why we did it, and the patient went okay. I'm not saying that we should omit the role of neurosurgeon, but this is actually what we did.
Yeah,
great.
My question, Mahmoud, is that do you have any experience with the ectopic implantation? You know, some people, if you have a crash injury and you can do primary repair and the hand is really viable, but the forearm is not ready for repair because like crash injury. Some people, they do ectopic, they put it in the leg or something like that. Do you have any experience with something like that?
Well, actually, you know, I didn't do this, but I know that if you have to implant this hand in the leg. I have seen some papers about this, and some put in the abdomen, and they connect to the inferior epigastric for some 2 weeks, 3 weeks till the forearm is ready, and then you go back and re-implant it. But actually, I don't have personal experience in this.
Okay, thank you.
Thank you very much, Sam.
Dr. Sandeep, what is the situation in Nepal? Dr. Sandeep?
Professor, I think Atif Salam have a question and his mic is open until Sandeep comes. Do you like to speak, Mr. Professor Atif?
Yeah, please.
Okay.
My mic was muted.
I just want to congratulate Dr. Salah. These are very demanding cases, and I'm glad the point of delayed repair of nerves has been discussed, because that's important. And you need to have the microscopy to co-opt the two ends of the nerve in the right direction, and special sutures, special techniques. But if you don't have choices, you do the best you can.
Atif, thank you very much for this comment, and I completely agree. If we have a neurosurgeon, definitely he will do better than what we are doing in the nerves. But if you don't, if you are choose between to do it or to leave it, I'll do it. I don't know what's your opinion.
No, I think it depends on the circumstances. The legal side of it has been raised in some cultures, like in the United States. You have to be careful. And not every neurosurgeon, at least in the States, there are neurosurgeons who don't work with peripheral nerves. It's a specialty in itself now.
Okay, we can take a quick comment from Professor Badaria and Professor.
Dr. Mohammed Shamari?
Yes, Mohammed Shamari.
No, Dr. Sandeep first.
Yeah, it's not much common in my practice, the transplantation of amputated limbs. But sometimes the plastic surgeons and orthopedicians are doing these cases. But I'm not much familiar with this implantation of amputated limbs, not much.
Okay, thank you. Dr. Mohammed, please.
Well, I'm a radiologist, so this is beyond me, but very nice lecture, Dr. Salah.
Thank you very much, Dr. Muhammad Allah.
Yeah. I just want to ask Professor Mohammed Shamri, I know you are very good intervention radiologist. Do you see intervention radiologists doing this procedure in the near future, Mohammed?
No, not really. No, I hope not.
I hope not also.
Yeah, trauma is a different thing.
Okay, back to you, Professor Ayman.
Okay, I think we have finished, and I will leave the mic for you for questions from the attendees.
Okay, we have 5 questions from attendee. I will take them in the time order they have put the questions. It is very democratic system. So the first question is by Dr. Ghazi Al-Nabolsi. Your mic will be open in 10 seconds, Dr. Ghazi, and you can ask your question to Dr. Mahmoud. Go ahead.
Assalamu alaikum, Dr. Mahmoud. Really, it's a great lecture. Thank you so much. I have one comment and one question. My comment actually for primary repair of the nerve injury. Actually, this re-implantation surgery, it's not like trauma surgery. After the re-implantation, nerves should be done at the site. As you said, nerves in front of you, there is no need to go back and do more trauma for the patient, and you need the best circumstances for the patient to success this re-implantation. Second, my question for you, is there any rule for RTBA in the preparing of the amputated limb before re-implantation, or just you flush the artery and the vein with heparin and saline? Thank you so much.
Thank you very much, Dr. Ghazi. At least you supported my point about the nerve. Concerning your question about the, actually you take the limb and wash it first, because usually it's coming with dirt and these things. And then after you wash it and you sterilize, then you start flushing from the artery till you have clear fluid coming from the vein. You start from the, for example, brachial artery, flush with saline heparin only, saline heparin, a lot of saline heparin to get all the blood from the amputated part till you have the clear fluid coming back, and that's it. We don't put TPA.
Excellent. Thanks very much. The second question is from Dr. Sadoun Al-Ubaidi. Dr. Sadoun, you can go ahead and ask your question, Dr. Sadoun.
I don't know how to connect with you by the web. Are you hearing me?
Yes, we can hear you. The mic is on. You can ask your question, Dr. Sadoun.
Okay, thank you very much for this presentation. It is nice to reimplant such amputated limb. And everything I see, it is all right, and all his talk, it's so scientific, because he is the leader, and he must decide to reimplant everything at once, even the nerve. I faced many cases, really about 3 in my life as a vascular surgeon, but not totally amputated, nearly total, just the bone was in, and I do the same. Everything I did by myself, but really I don't need the orthopedic because the bone was not broken. But I reimplanted the arterial and the saphenous, the tendons, and also I reimplanted the nerve because it's so difficult to get a neurosurgeon at these times. It's well done and very nice, and I think it is the right way to do this. Thank you.
Thank you very much, Dr. Sadoun, for your comment.
Okay, I think I will take one last question for the sake of time, and we're all eagerly waiting for Professor Radwan. Great presentation. So let me ask Dr. Aram Baram. Aram Baram, your mic will open in 5 seconds and you can ask your question. Dr. Aram. You can open your mic, Dr. Aram. Okay, I think there is a problem with his mic. I will give back the mic again to you, Professor Ayman, to go ahead for the excellent last presentation by Professor Radwan.
Okay, thank you. Now the time for Dr. Radwan. Dr. Radwan is a senior consultant of vascular and endovascular surgery in the International Medical Center, Cairo, Egypt. Is a president of Egyptian Vascular Club and editor-in-chief of Egyptian Journal of Vascular and Endovascular Surgery. Is the examiner and Egyptian convener for examination for Royal Vascular Surgery of England. Dr. Tariq today is going to talk about capillary venous malformation. Please, Tariq, the mic is yours.
Thank you, Ayman. Can you hear me?
You can raise the voice a little.
Very low. If you can raise your voice.
Can you hear me now?
Yes.
Much better, yes.
All right. Okay. Thank you very much, Ayman and Muhammad. Actually, I'm very delighted to talk after the 2 great presentation by my colleague and my friend, Dr. Mahmoud, and our professor, Dr. Martin. I will share with you my slides now. Can you see it now?
Yes, yes, we can see it.
Right, okay. Now, as Ayman said, I'm working in the Army, in the International Medical Center, but this is my new hospital. My training started early at Maadi Armed Forces Hospital. I was very delighted to see Professor Atif because he is one of my father experts teaching us at Maadi Army Hospital years ago. And once I saw his face today, I looked rapidly on my old files. So I found this photo. I would like to share it with Professor Atif Salam. This in Maadi might be 87, 88, something like that. I know, can you see the pointer? Can you see the pointer or not?
Please send me a copy.
We can see
All
the
right,
picture, but we can't see the pointer.
Okay, all right. Now I will get it with my mouse. This is, can you see this pointer?
Yes,
Not
we can see it now. It's a bit
okay,
small, but we can see it. Yes.
This Professor Shulami, God bless him, he's the father of vascular surgery in the army, all right? Might be someone before him did this, but he's what I have learning under him. Second to him is Professor Adil Ilham. He's one who over all of us, you know him, and most of you has been teaching with him. Professor Reda Gohar is also okay. Professor Reda Gohar is one third after Professor Adil, and he was the CEO of the International Medical Center where I still working in him. This me, Ali Murad, Hassan Al Mahdi, and Khairi. So Professor Atif, I know him for years and years. I was delighted that I have many of my experience has been gained from Professor Atif Salam, and I'm very happy to talk in front of him today. This is my disclosure. My talk about the capillary venous malformation, but because if some audience have no much experience in vascular malformation, I will start my lecture with some rapid overview of the vascular malformation itself. So congenital vascular malformation are one of the most common congenital and abnormalities with the diagnostic and the treatment dilemma in Egypt. And I think it is not in Egypt, it is in many areas in the world. They are often misdiagnosed. Vascular malformation always misdiagnosed. You have patients referred to you from any center with many unnecessary investigation, like this patient, someone did for a patient an ultrasound and an MRI and a CT angio and a direct angiography, and then lastly, the comment from the radiologist come to you, it is a probably vascular malformation. So the problem with the vascular malformation is first, how do you diagnose it first, and then you differentiate it, and then you treat it. In 1996, earlier than this, there were many classification trying to classify them, but in 1996, the ESVA classification, which is the International Society of Studying of Vascular Anomalies, have a very nice biological, embryological classification, which showed them as first as vascular tumor, which is most of them is the infantile hemangioma. You can have others here, but this is the most famous in them. And the vascular malformations themselves, they classified them into by the flow into low flow or high flow. The low flow is a capillary malformation, a venous malformation, or a lymphatic malformation. The high flow is the arteriovenous or the arteriovenous malformation or the arteriovenous fistula. Rapidly, let's go to the pediatric hemangioma. The first thing, usually it is not present but appear later on, some weeks later, show rapid proliferation during the first months of life or year, and followed by a slow involution. For diagnosis it, you depend on the clinical examination, the history, and the ultrasound, because the ultrasound will give you, although it is a solid tumor, but it have a criteria of high flow vascular malformation. And then MR is usually homogeneous with no specific character. So we don't depend on MRI unless we want to differentiate it if we are not clear. This one of the cases we've been used it for years before, using steroids, using vincristine, using some drugs, and then in 2008 propranolol was discovered, and we use oral propranolol in the dose of 2 to 4 milligram per kilogram body weight per day. This is a young child, 3 months age, with a huge swelling. The left cheek, you can see the swelling on the MR, and then after 1 year of treatment with propranolol, complete disappearance with no any interventions. This is a much good result in it. The other thing is the capillary malformation. Capillary malformation, it is just an cutaneous thing, and like we called it the port wine stain, sometimes associated with hypertrophy or facial the facial skeleton. Treatment is usually by laser, and it is outside our scope now. The low flow malformation are congenital lesions secondary to error in the development. Majority of these lesions are sporadic, but sometimes associated with heritable syndrome, like the most famous of them, the Klippel-Trenaunay syndrome. There is lack of arteriovenous shunting, so there is no pulsatility or erythema as you find in the AVM. You depend on the flow slowly on the MRI. In the venous, it gives you on the like on the left side an patchy area of contrast enhancement or flow appearance, but in the lymphatic it shows no contrast enhancement. For the treatment, you usually do direct puncture. It's a sclerotherapy, as this gentleman is a 25 years old male presented by the left supraorbital swelling. You can see it in the MR. You treat him with direct puncture under fluoroscopic control with ethanol, and after 3 or 4 treatment sessions, there's a good improvement, nearly disappearance in the MR pictures. And this is the follow-up photos, and with nearly disappearance of the malformation. The AVM is the high flow, the type of the high flow. It is something different. It is low resistance communication between the artery and the veins without an intervening normal capillary system. It is usually pulsating, hot. If it is cutaneous, you'll find it pulsating hot. If you put your hand on it, you will feel a thrill. You will feel the pulsatility of the lesion. They are the most common complex of the congenital vascular malformation, have significant hemodynamic alteration. In the large area, you can have a high flow cardiac output failure, arterial insufficiency like the steel, or chronic venous hypertension. If you do an MR for the AVM, usually you don't find a mass lesion, so usually we depend on the CT angiography or direct angiography. This one of the case of the pelvic AVM, you can see direct angiography give huge rapid filling of the vein, but before it goes to the rapid filling of the vein, you will see an area intervening, which is the nidus, which is our target of treatment. There is many classifications of the AVM, but the one which I usually follow, because I have Professor Atif Salam. We also have another professor, Professor Yex from Colorado in USA. He's one of the eminents in vascular malformation, and I have all my experience getting from him. I'm working I'm seeing him for nearly 15 years now, and get all my experience behind him. We have many classifications, but in my work, I depend on the Yex angiographic classification. He classified the AVM on the angiographic classification. So you need to depend on the angiography to classify the AVM, and it is 5 types. And the most important is AVM, you attack the nidus. You have an artery and a nidus, and then the vein. When you are going to treat, you need to treat the nidus first, because if you treat the artery, which is a supplying artery, you can affect the normal tissues, and you can get many disadvantages or back throw from the treatment. This one of the case of the AVM, 32 years old female, have presented by log band for years. CT angio show massive Yates type 2A AVM treated by direct angiography and then coiling, large coil. With this large coil, just to close the venous side, and then you put a lot of coils inside until you occlude it, and you continue with some ethanol around behind it until you get the completion angiography with disappearance of the AVM. This one of the one-stop shop, it's finished, but you have to put around 39 coils, Nestor coils in it, between 8, 10, and 12 in it. And this is her CT angio in 2 months follow-up, and this here 3 months follow-up selective angiography with disappearance of the AVM. So all the previous is just if any one of the audience is not familiar with the AVM, we just covered how much the AVM are classified and the methods of treatment of most of them. Back to the ESVA classification in 2018, they show us the more advanced classification and more clarification as vascular tumor, which is benign, but the vascular malformations, they showed us a simple, as we mentioned before, like the capillary, lymphatic, venous, arteriovenous. It is one entity only, or combined. And combined, you can two or more together, like capillary venous, capillary lymphatic, lymphaticovenous, many types you can. So our topic today is about the capillary venous, which is the malformation between the capillaries and the venous malformation. So it is two formation together. And in this situation, it is not the clipal trinony with some capillary malformation. It's not two separate. It's both of them are in the same lesion. So it's something different than the clipal trinony syndrome. So capillary venous malformation are low malformation, all right? Low flow, they are malformed capillaries and veins. The arteries are normal, but enlarged. And the most important, when you do the direct angiography, as you can see, there is no shunt, but there is intense filling of the vein. It is very tense, but it is not pulsating. So when you examine it clinically, it's not pulsating, and there is no thrill over it, but it is quite tense. And when you look at the CT angio, it is very mistaken to the AVM. You will find dilated veins, huge swelling, massive filling of the malformation, but there is no shunt. And this is the difference between the capillary venous and the AVM. Sorry, this just to show you. I will start this angio now. This is the difference between the AVM and the capillary venous. Capillary venous on the left side, but the AVM on the right side. Both of them is present in the check, and you can see on the right side of the screen there is shunting, rapid shunting between the artery and the vein. So I tried when we started to see cases in 2015, and it was a little bit strange for us. So I looked for on the literature how it is described in the ESVA classification, but it is not present a lot of it in the literature. So I found it rarely described with different nomenclature. It is this one of the very few reports written in 2009, and just describe it nearly as we said about it, but there is no much information about them. This my team in the International Medical Center, and this Professor Winieks, and when I couldn't find a proper description about these lesions, he told me I could find it only in the orthopedic literature. So I looked on the orthopedic literature, and I found it. They described it as an intramuscular hemangioma, but it is present, yes, only on the orthopedic literature. And also it is described in the orthopedic literature as the vascular type of the aneurysmal bone cyst. The vascular type of the aneurysmal bone cyst represented nearly 95% of the cases. Only 5% of the cases you found them as unsolid. And it is a rapidly growing destructive lesion inside the long bone, which increases vascularity. And so when I tried to find it, I talked to one of my colleagues in the International Medical Center, and he said to me in the orthopedic, he's a orthopedic consultant. He said, yes, we have cases of this. So I looked in one of his cases, destructive lesion in the upper end of the tibia, but in intraoperative, he found it a sac filled with blood. So this proved what we're looking at as an capillary venous. So our International Medical Center in Egypt, in the capillary venous malformation, this is the total cases we had it in the last 5 years between 2015 and 2020. Most of the cases, as the literature said, we have is veno-lymphatic, some lymphatic. Capillary venous, we have 17 cases only. In total, 3,000, nearly 2,000 cases. We have 64 AVM and 6 AV fistulas. Most of the AV fistulas we have is in the pulmonary AVMs. This is the distribution of the case, 17 cases, 8 males and 9 females, age range between 2 years and 55 years. And we did number of treatment session was 86. This is the distribution of the cases according to the site. Most of them came on the head and the neck, followed by the lower limb, only 1 in the trunk and 2 in the pelvis. This is my treatment protocol as we learned it from before. We do all the cases under day case anesthesia. For the capillary venous malformation, they should do an angiography with direct puncture into the malformed veins with undiluted ethanol, because we depend on the ethanol on our treatment. If you do super selective catheterization, you do 50% only with 50% non-ionic contrast. Your ethanol injection doses should not exceed at any time more than 0.1 milli per kilogram idle body weight every 10 minutes to avoid the increased pulmonary pressure and cardiopulmonary collapse. Post-operative, use non-steroidal anti-inflammatory, tapering steroids, and PB receptors, antagonists, and then the post-procedure monitoring for 6 hours and then discharge of patient. But because it's not an easy job, you have all the time to remember the reported in the literature potential complication of ethanol impulsotherapy in any of the vascular malformation. It is a huge complication rate if you don't know how to use it. So you can have tissue necrosis if you have non-target ethanol embolization, as I mentioned before in the AVM, if you inject it in the main artery. Vascular spasm, edema can lead to localized skin blisters. You can do injury to the adjacent muscles and the nerves, motor sensory nerve injury, bleeding, and most important, you can have venous thromboembolism. And in my life, in the last 15 years, we have 2 patients died on table with simple venous malformation, just for the venous thromboembolism. You can have pulmonary arterial hypertension and cardiac collapse. So please, before you use ethanol, you need to know its potential complication, and you need to know how you target it. This, I will just show you some of our cases in the International Medical Center. And please, Dr. Ayman, if you find this exceeding the time, just tell me, because it's around 5 to 6 cases we can show.
You're doing great, Tari. You're doing great.
Okay, right. Thank you, Dr. Mohammed.
About
what?
5 minutes.
5 minutes, thank you. So I will not show all the cases, I'll show some of them. This one of the cases, 15-year girl with a swelling of the forearm, diagnosed as an AVM, but when you do the direct angiography, there is no shunting. You do direct puncture ethanol, undiluted ethanol, and you can see on the middle screen how it is sclerosing happened in it, and the completion angiogram showed no devascularization of the lesion. This is her MRI 3 months later. Another case, this is what I said, it is an capillary venous malformation in the pelvis. If you look at the CT angio, it looks like the AVM, dilated veins, dilated arteries, and huge swelling. But when you do the direct puncture in it, there is no shunting, there is no rapid venous filling. It is just intense filling. You do, this is the case after 3 to 4 sessions. So I will pass this is another one interesting capillary venous malformation of the cheek. This is also treated in one session. I will show this also. And I'm sorry, this is the difference between the start and the completion angiogram with devascularization of the lesion. This is another interesting case in a child with an ulcer, bleeding ulcer, and complete healing later on. This one of the tibial capillary venous malformation of the bone treated, but just one treatment sessions. This patient was lost for follow-up later on, so I just have one treatment session for her. This one type, we called it pothroides. It is like a sarcomatous lesion in the ear, but it is actually again a capillary venous malformation. So we have no, this is our treatment results, 17 cases. We have 4 patients cured, 12 patients having going treatment, because in going treatment means you could have symptom improvement, fibrosis on the MRI, or good devascularization, follow-up angiography, because most of the vascular malformations are chronic lesion. You can treat it once. It is it's very successful if you can get it from one session, but most of them take many sessions. We have no major complication, only small skin ulcer. So in conclusion, my dear colleagues and my professors, capillary venous malformation are malformation with malformed capillaries and the vein. They demonstrate increased vascularity with no shunting, and angiography is important. And we, as I said, the treatment protocol, you do direct puncture with undiluted ethanol or 50% ethanol and super selective, and the orthopedic medical literature has mentioned it as intramuscular hemangioma or aneurysmal bone cyst. Now, I think it is the time that to tell you, don't miss our AG VASC 2020s, and I'm happy that Professor Salam is with us. It is 10 to 13 December 2020 this year, with Professor Ayman Fakhri, Professor Musa'ad Salman, and Professor Muhammad Omar Al-Farouk, and we'll have a vascular malformation day in this session. Thank you for your kind attention.
Thank you, Tariq. Excellent lecture and very good series. Congratulations for keeping work for more than 15 years. This is marvelous. Thank you, Tariq.
Thank you.
I think we have many comments from the panel. I think Dr. Amr Abdulrahim is interested in AV malformations, and I think he wants to comment or ask you.
Okay.
Professor Tariq, very nice presentation. I'm very delighted with it. Concerning the malformation, what about the using other agents like the cyanoacrylate or glue? Actually, I tried to do many cases for AV malformation with the cyanoacrylate. The process is different, I know, but why it's not that popular, and it may be a solution for many cases with AV malformation.
Thank you, Dr. Amr. You're welcome. The thing is, you have many. You have Onyx, you have STGS or ethanolamine, like the foam or something. But the reason we use the ethanol for 2 reasons. First of all, because I've been trained with Professor Yates, and he's the founder of the ethanol sclerotherapy. And when we compare the cases of onyx, the STDs with the ethanol, even bleomycin, you can use it in some of the low flow malformation. We found ethanol have the best result because ethanol do denaturation of the endothelium. So in my experience or my knowledge is that it is the only agent that do complete destruction. Once you devascularize the lesion, it will never return back. And you might use, I usually use STDs or esexoscleral foam sclerotherapy in the dangerous areas if you have it around the ear, around the eye or in the digit. But I usually find it is you need more sessions and you need you see some recurrence. But most of the ethanol cases, once you destruct it, as I told you, you found it is the best choice in the treatment.
Thank you, Tariq. I see Dr. Martin raising his hand, and I think he has to ask you. Dr. Martin, please.
You need to open your mic, Martin. You cannot hear you.
Hear me now? Is it better?
I can hear you now.
Yes.
Dr. Tarek, it's just I want to congratulate you. It's the impressive number of patients. It's amazing, and I cannot wait to hear from Mohammed Al Shamari, who is perhaps the best expert on this panel about this topic. So let's ask him about his comments.
Thank you, Dr. Martin.
Okay, Dr. Mohammed Shamari, I think you have a big comment, but try to make it clear.
No, King Faisal Hospital, Riyadh, we have vascular anomaly program. We have about 1,500 patients. And actually, people need to know, it's not the embolization that is the important thing. It's actually a multidisciplinary team. You need surgery, plastic surgery, pediatric surgery, orthopedic, sometimes ophthalmology. You need rehabilitation. It's a multidisciplinary approach. It's not just a procedure thing. So, and you need to know, and patients need to have the expectation that they will not go to normal, but the attempt is to reduce their suffering. And as Dr. Tariq said, there are multiple procedures. In King Faisal, we like to use less alcohol, but we have Patricia Burrows, and she's in the molecular trans, the classification. She's visits us every 6 months, and her school is to use combine more than when sclerosing agent as a principle, not just ethanol, but you can use bleomycin, STS, and sometimes, and depends on the case. Sometimes we even use laser, big veins, we laser them. So it's each case is different. Each case need multidisciplinary approach and decision, and to have a really expectation of the patient and her family or his family to be known, so that they would know that we're here not to cure him, but just to reduce the suffering in most patients. Sometimes you have small cases, limited small malformation, venous malformation that you can cure completely, but the vast majority of the cases are complex. They're going through the muscle, through the bone, and you just need to reduce the suffering.
Thank you, Dr. Muhammad. It's a very nice and appreciated comment. I agree with you totally. It is a multidisciplinary team, and I think this is what we do. It might be, it is not the scope of the lecture, but if we talked about the program itself, you will find it talking about this. Yes, counseling with the patient is very important. This is the best and the first step we have to do, and we suffered a lot in the start to manage this with the families, and usually you have anxious patient or anxious families, and by the time after the second or third session they start to accept what is going on. Personally myself, I use ethanol, as I said, and mainly, and I use STDs or ethanolamine foam, esexoscleral foam, which is a bludicanol in the digital or hands or feet. This is my own. I tried the bleomycin, but I found some complications, systemic complications with bleomycin, especially in the some pigmentation. In the young girls, we have some problem with their hair, so I stopped it, and I don't find it much benefit rather than ethanol, so I return it back to the ethanol. It is a multidisciplinary. We have a good radiologist, good pediatrician, good anesthesia team, and usually we take the decision together. So it is just outside the scope of the lecture, because Dr. Ayman is always telling me don't exceed the time. That's it. But thank you very much for your comment. I appreciate it.
Now I think Dr. Badaria have great experience in AV malformation too. What do you do in India, Dr. Badaria?
Oh, actually, I don't have any experience in this, but I would like to experts here, Dr. Adwan, to really clarify one particular point. We were under the impression here that when we talk of capillary venous malformation, we are talking of those conditions which have a cutaneous lesion. And what you showed basically are what are basically we call just low flow venous malformations. So those conditions like a Klippel-Trenaunay or Sturge-Weber, where there are port wine stains, we'd call capillary venous malformations. And others which would have low flow venous malformations, call them just plain venous malformations. What is your comment on this particular aspect?
All right, thank you very much for this very nice question, which showed that you are expert in what you said today. But as I mentioned before, a capillary venous, as described in the ESBA classification, it is not two separate lesions. Klippel-Trenaunay, you have extensive venous malformation, and you have capillary malformation of the skin. It is two separate. But in the capillary venous, it is one lesion, have dysplastic veins and the capillaries. And so it is causing intense filling of the veins. It's something, it is not the low flow, because in the low flow, you don't have dilated arteries. If you do an CT angio for a capillary malformation, as I showed you in one of the cases, you see in a picture mimic the AVM, but it is not an AVM because there is no shunting. And again, it is low flow because there is no rapid flow, there is no rapid communication. Venous malformation has no dilated arteries. Venous malformation, the low malformation, venous or lymphatic, it is just slow flow, but have no dilated arteries. So it is separate lesion. So it is something between the AVMs and the low flow malformation. It is different entity.
Professor, how would you explain what is the reason for the dilated arteries in this particular case?
I think it is because of the huge swelling and the dilated capillaries and veins. It has by the time there is a big flow going in it, but it is not going as an AVM shunting. There is no shunting, so it is just intense filling affecting back pressure on the arteries, because it is when you look at the lesion, it's quite tense. It's a huge coming. So by the time the artery is dilated by the back pressure, but this pressure is not reflected to the venous side. On the other side, there is no shunting.
If I may add one more last question here.
Yeah.
And this is related to the Klippel-Trenaunay syndrome.
Yes.
We are treating this with a combination of foam sclerotherapy, lasers, and recently I've also been using microwave laser, which I find much more effective. I don't have to use so much of tumescent anesthesia. The question basically to the panel is, and you, is how many people actually use low molecular weight heparin before and after the case, because some of these patients can develop intravascular coagulation.
Yeah. Can I comment, or anyone of the panelists want to comment?
Please, you please.
Right. Thank you very much. You touched a very hot and interesting point for me, because every year I have many patients with Klippel-Trenaunay. We have it's very widespread in Egypt and might be in your country also. The problem is that every year or every 6 months, we hear that a patient of them die spontaneously, probably as described in the literature with venous thromboembolism. And so on the last year, I raised this question for many of the panelists in the vascular malformations workshops or meetings in the VIS and the Charing Cross, but we don't find a definite protocol around the world. I started actually in the last year to start the DUAX for life for them continuous, because we trying to decrease the venous thromboembolism can happen spontaneously. In the clebeltrinone, if we in the labs of the patient, if we have change in the bloods with it, because some of them has syndromes with change in fibrinogen D dimers and FDBs. If you find this, we put them on low molecular weight 2 weeks before the procedure and sometimes after. This one topic. But for them, usually, if they don't have a bleeding problem, I put them in DUAX or NOAX prophylactic dose all the time.
Thank you.
Great. Before I leave the mic for Omar, I have a question from Dr. Atif Salam and a comment from Dr. Mahmoud Salah. Let us start by Dr. Atif.
Thank you, Dr. Ayman. Thank you, Dr. Tar. So much means to me a lot to hear you and see how far you've gone and your scientific approach to a problem like this. The message here is you have to really, it's custom made. This is a spectrum that you cannot have one size fit them all. Having said that, you have seen patients that come to you, they were mistreated before you see them. And as we tell our fellows, don't repeat our mistakes. So 2 mistakes that come to mind, and I'll let you tell us about your experience. Patients presenting with massive varicose veins, and the other side is completely normal, and people don't go into the details of the physical exam, and they treat them as for stripping or a laser or something, and that's, of course, a mistake. The second mistake, in the high flow, hyperdynamic situation, it's tempting for someone who doesn't understand the hemodynamics to go in and interrupt the main artery, which is a wrong approach, because the collaterals will be reversed to the low resistance system. So you ligate, ligating the main artery, and the collaterals are already flowing in the wrong direction, and you may precipitate gangrene in this situation. So I'd rather listen to the expert. You tell me what are the mistakes that you've seen done by other people?
Thank you, Professor Atif. We all consider ourselves as your students, not. Thank you very much for your comment. I think there is 2 points in this. As you said, the extensive dilated veins. It could not be just varicose vein. It is congenital venous malformation. And so when we see a patient like this, we ask for an MRI first to see if there is deep extensions or this is deep lesion. Also, we do the duplex because, as you mentioned, some of these cases have deep venous anomaly, and you might have the deep veins absent. The infragluteal veins are not present at all. So if you treat the superficial veins, you get with extensive venous hypertension and maybe a problem. In the AVM, yes, we attack. What I learned is we attack the nidus. The nidus is the thing is just after the normal artery. So usually attack the nidus, either direct or super selective, reaching the nidus, and then we start all the treatment from the nidus to the normal veins, so we don't affect the normal tissues. In Egypt, and I think Ayman and Omar knows that, for years now, and might be Dr. Amr, I know, for years now, we started like some sort of announcement program from the International Medical Center. In all of our meetings, we talk about the malformation, how to diagnose, how there should be a multidisciplinary team. And we started. The reason of the large number I have, I think because in our center now, the experience that we started to have many referrals So we see most of the cases at the first instance before someone trying to do it, which is not expert in it, and which is means if he know it, he will do it. If he doesn't know it, he will refer it to another center. I hope this is an answer.
Great, Tariq. Now we shift to Professor Mahmoud Salah.
يعني fascinating as usual يا طارق والله. يعني I cannot tell you how much I enjoyed the presentation.
Thank you, Dr.
My question is, the first case you showed, you put a coil in the vein before you start attacking the nidus and fill the malformation with a lot of coils. Is this what I understood? I understood correctly?
No. We filled the nidus. There is a huge nidus. So if you put small coils in a rapid shunting AVM, these coils could just disappear and goes upward in a flow upward to the lung. So what we do on a large coil just to fill the huge nidus and then fill it, but it is on in the nidus itself before the venous side. You do direct puncture to the nidus, not to the vein.
Thank you very much.
If I showed the preliminary angiography, it would be more clear, but it is just I showed rapid pictures of it.
Thank you, Dor. Thank you.
Thank you.
Thank you for the panel. Now I leave the mic for Omar. Please take over.
Okay, thank you very much, Professor Tariq. You did encourage a lot of questions. I will take some of them because of the sake of time. The first question, which was put on the Q&A button, was from Dr. Haidar Badi. He said, Dr. Radwan, what is the dose of ethanol used? Is it painful and need GA? I know you do it under GA routinely, but what is the dose you are using, Professor Tariq?
Yes, routinely we do, as I mentioned in my slides, it is very painful. So you have to use it under general anesthesia. There's one reason for general anesthesia. The second reason is that you don't want to miss your lesion. If the patient does any movement, you will get out of your target lesion, so you make mistakes. So the patient needs to be flat. That's why you need under general anesthesia.
Okay.
The dose is, the dose is for the low malformation. The maximum you have is 1 milligram per kilogram body weight per session. But actually, this is the maximum. Actually, in my experience, to avoid any complication, I don't usually exceed 0.5, 0.6 per milligram per kilogram per session. For the AVMs, if you do transcatheter, you need, as I mentioned, to do it not more than 0.1 to 0.14 milligram per kilogram every 10 minutes. This is avoid the rapid flow of the ethanol to the pulmonary circulation, because with the ethanol you could have pulmonary collapse if you done a rapid injection. And some centers both Swankens, caster in every patient to monitor the pulmonary pressures. But with this dose, which is it is not my dose, it is written in the literature, and it is recommended by the ISVA group. And it is if you stuck to this lesion, you avoid any flow from your nidus to the pulmonary circulation.
Okay. And another question from anonymous attendee. He said, in which cases would you use bleomycin?
As I mentioned, Mohammed, bleomycin you can use in the low flow malformation, and many centers has experience with it. My experience with it is a little bit limited because when I tried to compare with ethanol, I found the ethanol much effective, and with the target lesion has less side effects generally. So I stopped using it. But bleomycin is a well-known and used, mainly they use it in the low-flow malformations.
Okay, and one of the last question I will take from Q&A is from Dr. Haidar Badi. He said, can you combine ethanol with a sclerosing agent to reduce the dose of ethanol? And we have used it in our center with monitoring of the patient with blood pressure and other monitoring. What is your comment? To use the combination of
Yes,
ethanol and
yes,
the
you
sclerosing agent.
can use ethanol with say foam polydecanol, but I just want to tell you that no one of them is safe. No one is completely safe. From the foam itself, you can have cardiac arrest and you can have pulmonary embolia and these things. So you have to be cautious here and here. But my personally, when in the because for the problem of the you know, say if even if using low flow malformation in the digit or the fingers, and once you sclerose the malformation, it will press on the surrounding, so you can press on the digital artery and can cause ischemia. So I use sclerosing foam to the digital lesions, and yes, you can combine this and this.
Okay. With this, I would have finished my Q&A session, and back to you, Professor Ayman.
Thank you, Omar. At the end of our session today, I would like to thank Survey Company for sponsoring this great meeting. Also, I would like to thank our speakers, Dr. Mahmoud Salah, Dr. Tariq Adwar, and Dr. Martin Mersch, for their great contribution. Also, it's an honor to thank all panelists, Dr. Mohammed Shemari from Saudi Arabia, Dr. Badare from India, Dr. Sandeep from Nepal, Dr. Amr Abdurrahim from Egypt, Dr. Samir Kosair from Saudi Arabia, and our dear Professor Atif Salab from United States. I would like to thank my dear co-moderator, Dr. Amal Farouk. Also, I am in debt to the company Prime Partners for doing all the facilities to keep the momentum going. Before you leave all, please mark your calendar for next Friday at 8 p.m. We have 3 eminent speakers. We have Erwin Donder from Netherlands, Lowell Kapnick from United States, and Rashad Bishara from Egypt. I think it will be a very nice meeting next Friday. Please mark your calendar from today. Now we have to say good night. And you have
I would like to thank Professor Atif Salam for sharing this meeting with us in his very busy time fighting Corona in the United States, and we're always delighted to have you. Back to you, Professor Ayman.
Thank you, Omar. Now, please take care, keep safe, and see you next Friday. Goodbye.
Thank you very much. Thank you very much.
Thank you. Thank you.